For many years, about 40 that I'm aware of, we've been treating this very difficult problem, medication overuse headache, with 3 different directives. First, we have to explain to the patient exactly what's going on, because most patients think when they have a headache they should take something for the pain or for the headache or for the other symptoms. And if they have more problems, they take more. They don't realize that if they take it too frequently, that is 5 days a week instead of 1 or 2 days a week, they'll actually get worse, and it's harder to get them better. But when you say that to a patient, they get very nervous because they're dependent on this medication, even though they're still not feeling well. So the way we've always done it, we educate them, we detoxify them by telling them to stop the medication that they're overusing, either abruptly, which is what most people do, or gradually, which is what I used to do, and then just put them on a very good preventive medicine, something they take on a regular basis, to decrease their headache. Up until a few years ago, we didn't have great preventive medicine, so it didn't always work that well. So it was the most difficult thing that I've done in my neurologic career, was to try to treat these people, because I didn't have great medicines and I was taking them off their crutch. Now we have medications that are preventives that are a little bit better. We have 2 groups of them. One is an injectable called a monoclonal antibody against calcitonin gene-related peptide, or CGRP. And more recently, just since about 2020, we start to have 2 gepants, which also work against CGRP, but they're much shorter acting, and they're usually used for acute care of migraine, but there are 2 forms of them that can be used preventively also. So my feeling is, when I give somebody one of these long-acting monoclonal antibodies, even though they're still on the medication that they should be coming off, they start getting better right away. So I no longer have to really intentionally detoxify them. So I simply say to them, I'm going to give you this medication. It's probably going to start decreasing your headaches a bit, and I don't want you to take as much of the medication that you are overusing, but you use it as you need to. But remember, if it's a milder headache than you're used to, don't take it, because ultimately I want you to either get off these medicines completely or just get them down to 1 or 2 days a week. The other side of the debate is, you still have to detoxify them because you want them to come off the medication. And it's clearly the wrong way, because it's much easier not to fight with the patient and fight with yourself to detoxify them, and that's what I'm finding I'm able to do. So it's an important debate, because I'm going to show the literature of what the most important people in the world have said about this. And they say you must detoxify them, and you have to do it abruptly. I never do it abruptly, and I certainly don't have to do it now. So it's a very interesting debate, and I think people will learn that my way may be a better way, and that will spread around the world. That's what I'm hoping. Up until recently, the literature definitely was against what I just said, because it didn't really include these brand new medications that we have. The latest literature, which I'm going to be showing, is a little incomplete. It's not exactly what we need, but it shows that even without detoxification, the patients get better. And it shows that when you treat somebody with medication overuse, they do at least as well as people that don't have medication overuse, and actually somewhat better. So when I put all that literature together, with my own personal experience, I know that it's not necessary to formally detoxify these patients.